Good morning. 50th anniversary. Congratulations, and we'll wait until the end and congratulate you for sure. I have 5 minutes and I'll go fast. 45 plus years of coronary stenting. What's new? These are my disclosures. Here it is. This is it. Andreas Grunzig,
water, please.
1977. Where are we today? We've gone through trials and tribulations, many clinical trials, many led by Dr. Greg Stone, who's here. The very first drug-eluting stents, bare metal stents first, then drug-eluting stents, and then improvement, constant improvement. And where are we today? Well, we know very well that drug-eluting stents are definitely superior than bare metal stents. And in fact, the second generation and the next generation, even better. And that is continuing to look wonderful with very low event rates in both cardiac death MI, hard endpoints, and myocardial infarction. A huge improvement over where we had been decades ago. However, over time, we continue to have some residual events, and maybe after the AHA meeting with select semaglutide and PCSK9 inhibitors and much better medical therapies that are coming, even gene editing, we might absolutely get rid of all of the residual events and perhaps improve even better our coronary stent outcomes. The technology continues to improve. We now, as you know, DES is a three-pronged approach. It's the stent, the polymer, and the drug, and continuous improvement in thinner struts, better polymer or no polymer, and of course the drugs that we now know work very well, and the application of the drug more on the abluminal side to enhance endothelialization. We know that the ultra-thin stent struts are evaluated, have been very well shown to reduce the long-term outcomes of target lesion failure, and very importantly, help us with endothelialization so we can apply it to the most difficult and complex cases. Our cases are becoming more and more complex. Polymer-free stent technology with microporous surface, porous surface, and drug crystallization and strut reservoirs have continued to improve our outcomes. And in fact, now with no difficulty whatsoever and no worries whatsoever, we can apply them to the highest bleeding risk patients. And in fact, they're better than any bare metal stent. And we are now looking at some of these newer technologies in the diabetic patient populations with the thin strut, polymer-free abluminal reservoirs, and of course, stents that are now being applied with CREATE for these patients in diabetes, where it showed better outcomes than Resolute Onyx at 1 year. At 2 years, things equalized. And now we are looking at the largest diabetic patient population. We'll present these data at ACC, 3,000 plus patients. This abluminous DES by Concept Medical versus everolimus-eluting stent, the Zion stent. We will see if there is some superiority with this very interesting DES and drug-coated balloon combined technology in over 3,000 patients. There's also now a concept of vasomotility restoration. The Dynamax bioadapter scaffold is a very thin cobalt chromium helical sinusoidal strands and PLGA bioresorbable limus coating, and very interesting, increasing compliance, pulsatility, vasomotion, and positive remodeling, well shown, and a prospective randomized trial is ongoing through the Sweetheart Registry, which we will see the results of. Restoring the vascular motility, vasomotility will be very important. We cannot have caged stents forever. I think that's another reason why this is being evaluated. So, new generation to stent technology still evolving, novel concepts coming forward. What's the role of bare metal stents? Thank you for your attention.